Welcome to Healthcare Du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare Du Jour is sponsored by SA Ignite, the law offices of Miracle Connell, and the Compliancy Group. And now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. John Halamka, the CIO for Beth Israel Deaconess Medical Center in Boston, and I can tell you I'm very excited to have you join us today, Dr. Halamka.
Well, I'm very happy to be here. I am joining from Unity Farm, so if you hear chickens, guinea fowl, and ducks in the background, it isn't the Beth Israel Deaconess Emergency Department.
That is good to know, although I'm based in Central Mass, so I'm not too far from the Tufts Vet School, so I might hear some of those sounds coming from there. But if you don't mind, I'm sure a lot of people are familiar with you and have heard about you before, but if you wouldn't mind just giving us a quick background in terms of what it is you do as the CIO for Beth Israel and just kind of who you are and what you do for the health IT field.
Well, sure. So as the CIO at Beth Israel Deaconess, I oversee 3,000 docs, 22,000 employees, and about 2 million patient records, the clinical, financial, administrative, educational, and research systems, and about 450 locations of care. I've also had a role at the national level overseeing a lot of the standards and interoperability development in both the Bush administration and the Obama administration as chair or co-chair of several federal advisory committees. I'm an emergency physician, a toxicologist. I do 900 patient toxicology consults a year, and I am a farmer. So if you want to ask about Obamacare or Llama-care, both are fine.
That I might take you up on that. My CSA is starting this week, so I'm looking forward to getting some very good fresh local produce. And actually, kind of touching on that comment, I've heard you speak before, and I know you've said that you're one of the nation's experts on mushrooms, and that actually leads to some interesting consults for you.
Right, and so of course as a mycologist I grow mushrooms and shiitake and ling chi and oysters and those sorts of things for edibility. But 900 times a year, 3-year-olds wander onto lawns, munch mushrooms, and parents wonder, is Johnny going to die? And inevitably the 3-year-olds are fine because the mushrooms are awful and they don't eat a lot. The 16-year-olds on the other hand, who are looking for the psychedelic experience, unfortunately, in the U.S. schools, don't learn the metric system. Do you know there's a difference between a gram and a pound? So they don't dose them quite right. But inevitably, after a little paranoia, they're okay. The worst, the adults with the Audubon field guide, they die.
Very interesting. It's I think probably something pretty unique in terms of the field out there. But to dive into more the broader healthcare and health IT related questions, I kind of wanted to go into innovation with you first. Hopefully we'll be able to kind of go in a different direction than I think some of your writings have been in recently, and be able to kind of expand upon that. So I guess when it comes to innovation, what does it actually mean to you?
Right, and as you say, innovation is more than just change for change's sake. What you hope is that you've saved people time, you've saved people money, you've provided a workflow that's more efficient or more convenient. And examples I've written about and talked about are my wife's recent diagnosis of hyperthyroidism was done via an iPhone, treatment done via an iPhone, prescription written via an iPhone. So when you think of doctor and patient using this as the means of rapid diagnosis and treatment, that sounds like innovation. You hope it's the freedom to experiment with new ideas without too much fear of change. And alas, in our society today, we're so risk-averse. We focus more on audit and risk because you could get struck by lightning. You better not go outside. Innovation hopefully gets beyond that.
Yeah, and I think that's a good way to put it. Is obviously being a lawyer, I am certainly well versed in the risk concerns, but at the same time understand that there are times where you need to be pushing the boundaries. Even though there might be some constraints or restrictions, you can still get to new solutions and into a new positive place.
Of course, you ask, what is risk? Risk is the likelihood of something bad happening times its impact factor. So if something is 1 in a billion chance of happening, do you really worry about it so much? If something could happen quite commonly but has no impact, who cares? And so that's where when I do innovative projects, like creating new applications with Apple, CareKit, ResearchKit, HealthKit, you say the patient owns the data on their phone. The patient can choose to share it as they will. As long as the patient's under total control of data flows, probably an acceptable risk.
Right, and actually, that's I think a very loaded topic in terms of the patient or individual ownership of the data. I've certainly seen a lot of debates about that on Twitter and other places. So, kind of, what's your experience been in terms of ownership, and with the apps or other tools that you've worked on? How have you been able to maybe shift the paradigm in terms of who is actually obtaining the ownership?
Sure. So recognize each of us have different preferences. My mother, who is approaching 80, has no real interest in downloading her XML formatted lifetime clinical summary onto her iPad and then being able to share it with others in her care team. She's totally comfortable with having providers do that on her behalf. Well, I'm a physician and a technologist. My wife is very tech savvy. My daughter, who's 23, is very tech savvy. All of us actually want to be the stewards of our lifetime medical record. And stewardship to us means liquid access to the data. After every episode of care, we get a copy of it to do with as we please. And that could be sharing it with a consultant, downloading it to Facebook, contributing it to research. Totally up to us. Because truly, HIPAA omnibus rule would tell you, you're a lawyer, covered entities have to securely deliver the data to the patient. But beyond that, it is up to the patient how they want to deal with the data.
Yeah, no, I think that's a good point, and it's certainly been a big focal point for the government about that access issue, which is, as you said, the individuals can get access to and should not be denied access to their information by the covered entities. So I guess in terms of being able to be that steward of the data, are there tools out there that you see are particularly useful or that you prefer to use?
Sure. So I have no stock or conflict of interest in any particular company of technology. So when I mention these things, purely based on personal experience. So what Apple has done with HealthKit is create kind of an interesting piece of middleware. Could I, as a CIO with my 2 million patients, interface to every single device that they might buy in their homes that's healthcare related? No way. But could Apple do that? Well, Apple, in partnership with Withings and Fitbit and Jawbone and everybody else, of course they can. So Apple contains, in your phone, a container with all of your device data. If I want access to it and you give me permission, I write one interface one time. And in fact, we did this. It took 1 weekend. And now I have a link between our electronic health record and the patient's phone for the exchange of data under the patient's control, because Apple created a container that made that possible. And Samsung, I'm sure, is working on the same thing. And I think what you're going to see consumer companies creating these containers that will make that exchange of data much easier than a provider organization like Beth Israel Deaconess could ever accomplish.
Yeah, no, I think that's a very good point. It's, for better or for worse, the healthcare industry or the entities or provider entities aren't used to doing that type of interaction, whereas, taking Apple for the example, that's really their whole business model, is making sure that they make utilization of their product as easy as possible for the end user.
Right, and so we've done a kind of interesting experiment at Beth Israel Deaconess that I think illustrates your point. We, as a paternalistic provider organization, recognized that patients couldn't possibly have their own mobile devices that function in a stable fashion. So we decided we would share data with patients in the ICU using iPads that we procured, we configured, and we constrained. Well, guess what? It turns out that doesn't work totally well. You have to sterilize the device between every patient. Try sterilizing an iPad. You have to ensure that all data is wiped. It's a nightmare. So guess what? We just wrote an app that enables any patient's device that they bring to the ICU to get the data about their loved ones and families for them to share in a social networking kind of fashion. And that was a learning opportunity for a provider organization. Apple, of course, knew that. We had to learn.
Right. So that kind of brings me back to a question, just with all the different technologies that are being developed and that seem to be flooding into the marketplace, is it changing too fast for the healthcare industry, or is the healthcare industry not reacting quickly enough, or kind of what are your views on the pace of where things are going?
Okay, so I had a recent conversation with a number of stakeholders, provider organizations, vendor organizations, and patients. And I think our concern is this. It's not so much that the pace of acceleration is too high. It's just, if you take the Meaningful Use program, and I've written about this a fair amount, we're trying to create too much too fast so that clinicians, for example, can no longer practice medicine. They're spending their entire visit doing keystroke entry. So we love patient-family engagement. We love safety, quality, efficiency improvements. We love outcomes that are keeping people well. But maybe the process focus of, doctor, you will enter 141 data elements at every encounter and you will like it. Oh, you're lazy if you're telling me it's too hard. Maybe that went too fast because we don't actually know what's worked and not worked. We haven't been able to refine what doctors and nurses and pharmacists and social workers, patients and families should do to create the end result of a digital healthcare system.
Yeah, I think that's a very good point about it. As you said, no one's been able to figure out what works and what doesn't. I know, as you said, I know you've written a lot about the Meaningful Use program, and it's, and I think your commentary and the commentary of others is, that program clearly drove and create the positive outcome of people have these systems, but now the question is, how do we get the systems to actually fit the workflow? So as you said, you don't have physicians or other providers who are just becoming essentially data entry people, because I've certainly had that experience when I've been at some of my providers where I just see their back because they're talking to me, but they're entering what I say into the computer.
Right, and so we're building a prototype currently of a Facebook wall for every patient. Now, of course, it doesn't run on Facebook. I use that only as an analogy. But if you look at today's EHR and you ask the question, so what's happened to the patient in the last 2 hours? You can't answer the question. You have a tab for labs, a tab for notes, a tab for x-rays, a tab for you got lots of data. But as a wall of the last 2 hours, can't really do that. And so our thought is, if doctors and nurses and patients and other carers need to communicate, and you did it on a wall, I bet that would be a whole lot easier than today's EHRs, and it would actually distribute the work. It wouldn't be just the doctor typing in every single observation.
Right, and actually kind of pursuing that idea, one, it kind of goes back to what we were saying a few minutes ago, which is it aligns with what people see in their everyday lives, because I think you're using Facebook as an example because how many millions of people across the world use that every hour of the day, really. So as you're pursuing that idea, is that something that everyone, including the patient and their family, would have access to?
And that's the concept. I mean, at the moment, we've created a prototype, and we're iterating that prototype through multiple stakeholder groups to figure out how it should work. Is it part of the medical record or not part of the medical record? Is it retained for discovery forever, or is it thrown away at the end of the day? These are all big policy questions we would have to answer. But it would just seem most rational that if you're having patient-family engagement, patient-generated healthcare data, and more of a team-based approach to healthcare, telemedicine and telehealth, wellness in the home, that you need to change the tools. And no one knows what tools we need to be truly successful with this next generation of merit incentive pay. So we're going to have to try a few things, fail a lot, but I bet at the end we'll figure it out.
Yeah, no, and I think that optimistic viewpoint is, at least my feeling on it is the right way to be looking at it, or not necessarily the right way, but where you have to be, because, one, I think healthcare is probably viewed as an industry that's never going to fail since you're always going to need it. But in terms of what that next evolution would look like, obviously I think it sounds like you're working on it. So what are your thoughts in terms of what you would like to see in the next iteration and kind of where you see things going in the future, which I think ties into a recent article that you wrote about the 5-year, kind of upcoming 5-year plan.
So, I mean, I could say several controversial things, like, do you think that the future of healthcare is in giant downtown ICUs staffed by Harvard professors with $40 parking and a 3-hour commute? Or is it at Walgreens and CVS, 2 minutes from your home with free parking, right? Of course, we'll always need tertiary care and ICUs. You'll always want someplace to go for trauma. But the very large bulk of care could actually be delivered in a minute clinic, or could be delivered in a suburban community hospital. And so I think what needs to happen is we need to decant the downtown academic medical centers and create, if not those suburban locations, then virtual locations where via telemedicine and telehealth, you get the care you need without the unbelievable hassle of having to commute what we would call the Mass Turnpike or Route 9, which Matt knows what I'm talking about. But take
Yes.
your city and just imagine a route by which you don't measure miles per hour, but hours per mile.
To get to that vision, I mean, really what it is breaking down the barriers across what have traditionally been different silos of the healthcare industry. Because usually, you think you have your physician's office, you have your pharmacy, you have your hospital, and each is operating on its own. But it really sounds like you're trying to create basically a horizontal overlay where there's an easy flow in between each of those locations and care is directed to the most appropriate locale.
And you're exactly correct. So I use this term care traffic controller, right? And that is, I'll give you a personal example, and it's completely fine from a HIPAA perspective. Don't worry, all consents have been released. My father-in-law died 2 years ago, but about 3 years ago he had a stroke. And so my wife calls me and says, my dad is starting to speak really funny. What do you think is going on and what should we do? And of course I said, well, you could go to the downtown academic medical center and call an ambulance. You could go to a PCP office for evaluation. You could go to a local suburban emergency department and get a CT scan. It's like the consumer has no idea which of these options is the right entry point for an event like that. But a care traffic controller would say, 2 miles from your home is a CT scanner staffed with an appropriately certified emergency physician who can triage your condition and bring in an expert by telemedicine. Time is important in stroke. It's also not only fast and easy, it's cost effective to go to your local community hospital. So do that. And so that's the notion of what Beth Israel's Deaconess Care Organization, or our BIDCO ACO, is doing, is create care management tools and care traffic controllers to help coordinate what is today a very disconnected healthcare system.
Yes, no, I think that's saying it's a disconnected healthcare system is very accurate. Working with different types of providers, I end up seeing a broad continuum. I think the ones that are more into the value-based or the risk-based contracting understand the need to have that flow that you're talking about, whereas the ones who are still, for lack of a better way of saying it, head in the sand, fee for service, an incentive to do it.
Right. I totally agree with you. And so I'm a doctor, right? So if I look at my medical school training, was I ever trained in the revenue cycle? No, I was trained in the Krebs cycle, right? I mean, we are taught as doctors how to manage the business of running a medical office, and so it's all by, as you suggest, oh, I get paid more if I do this. Why don't I do that? And so what we hope MACRA and MIPS, this whole new package of how reimbursement will work in the future, does for us is it will teach all aspects of the medical profession that you'll be rewarded for an outcome you achieve. And in fact, if it's a fixed payment, you will be rewarded for doing that efficiently. Quality per the patient preference with efficiency. So yes, refer to the community hospital. Don't do redundant, unnecessary testing. You know, recognize there are community standards and not just the apprenticeship you had 30 years ago. You don't need to order a head CT on every patient with a headache. Really? It's coming with realignment of incentives.
Yeah, no, I think that's a great point, which is, you know, as you realign and you can shift the attitudes, and you can get the tools that we were talking about, you know, to actually aid and encourage those types of activities, then I think that's where you're really getting to it. You know, I was listening to a recent podcast with Karen DeSalvo, and she was saying that, or suggesting that Meaningful Use implemented the tools that that MACRA MIPS and, you know, the new alternative payment models can now take advantage of.
And that's a fair way to put it, which is when I say the Meaningful Use program has met its goals, we should declare victory and move on. You know, what I mean is when David Brailer in 2004 told us with no budget and the ONC was a brand new office, we need to move from paper to digital because without digital data, we can't have population health, care management, or analytics. He was just quite right. You know, put an EHR to capture the data digitally. Then we can begin sharing it, do population health, etc. We've done that. Layering more and more and more data entry requirements on doctors, probably not the answer. Leveraging the foundation we've built with new tools to support a new level of incentives, probably the right direction.
Yeah, so kind of taking MACRA and MIPS up, I want to, I think, go down a road that you were saying that it offers an opportunity for education, both for practicing physicians, it sounds like, and, you know, maybe in my opinion, and I'll see if you agree, to build it into the medical education, because I think we do a disservice to physicians and other providers who don't get exposure to this, you know, when in their educational formative years. You know, the legal community is not really any different from there because law school has become this academic bastion where, you know, for better or for worse, when I came out, I had no idea how to actually practice the law, where at least in, you know, arguably from the medical perspective, you get the, you know, the on-the-job training of residency, which is, you know, kind of that medium step in between school and your career. But you know, I think there, again, in my opinion, there does need to be more built into the medical education process.
So what Harvard Medical School has done, and not that Harvard does everything right, by no means, but what Harvard has said is they've created a course for the first-year medical students called The Profession of Medicine. And that is the place where you learn about what is meaningful use and what are risk-based contracts and what is population health. And so when I went to medical school, and that was in the 1980s, of course it was biochemistry, anatomy, physiology, immunology. There was nothing actually, as you pointed out, about the business or the profession of medicine. So that has now come to the curriculum.
And that's actually very positive to hear, because my wife is actually a physician who was in med school in the mid-2000s, and, you know, it was about the time as I was starting to get into the healthcare law area, and she had never heard of anything that I deal with aside from HIPAA, just because I think I liken HIPAA to the Miranda of the health law field. And, you know, and then in terms of the business side, you know, it was very much a crash course even once she got out of residency. So I guess from the Harvard perspective, since that's where you're tied into, is there any idea or actual practical advancement beyond that, what you said, a first-year class, to kind of letting it flow all throughout the continuum of care or the continuum of education? Because as you also said, you know, you need to learn what is the appropriate type of care in the appropriate setting and not just throw every test at every patient.
So what I see happening in our EHRs, as I mentioned, so EHRs initially were kind of dumb containers that took what was the paper representation of the record and put it in digital form. What it's evolving into is decision support and workflow tools. So that is when a medical student goes to order a test, the medical student is actually educated by the computer as to the appropriate nature of that test, or what to do as a reflex test. If the test is abnormal, then what's the next test? And to give you an exact example, my wife was diagnosed with stage 3A breast cancer in December of 2011, and all of her treatment was done by computer. And that is, our computers contain all the protocols for all the cancer treatments. So the oncologist orders a protocol, but the computer actually executes the details. So the medical students are now able to experience that sort of expert system built into the tools they're using every day.
And no, that's very fascinating, and is actually probably a good way to go into the second avenue related to macro MIPS that I wanted to raise, which is, are we being over-regulated? You know, leaving aside the fact that probably, yes, obviously healthcare is an extremely over-regulated industry, but with all the new things that are coming out, is it stifling the ability to innovate and to kind of achieve the goals that are being established?
And of course, I've written quite a lot about this, and my answer would be yes, which is, if you go buy a DVD player from Best Buy, is the DVD in a blue box with 3 buttons with a bunch of certifications all over it? No, it just is certified that when you insert this silver disc, a good thing will happen. And so that's sort of my sense, is that we have gotten way, way, way too prescriptive in process, instead of focusing on achieve an outcome, and however you achieve it, Apple Watch or Fitbit, you know, up to you.
Yes. So given that perspective, and this is, you know, kind of a theoretical question, if you had total control, what would you actually want to change, or what would you do to the system?
Sure. I have talked to many vendors, and they say they are 32 months behind their customer requests, because I've had so many prescriptive requirements, they are unable to follow customer requests or innovate as they will. So we have to somehow figure out if the customer can drive the vendor's product as opposed to regulation driving the product, we'll probably end up in a better place. Interoperability, of course, as long as there's a business case to do it, isn't a technology limitation. Customers need to want it, it needs to have an impact, it needs to be alignment of incentives. Government, create incentives, create a payment scheme, but let the vendors and their customers figuring out how to achieve the result.
Yeah, and I think comparing it to, you know, the DVD player at Best Buy, or, you know, any consumer product out there, that's how it operates. It's, you know, the companies anticipate or respond to customer demands. It's, you know, they will follow where the money is going to be.
And it's very common for the vendors to be blamed as the evil actors, and they really aren't. I mean, I recognize that, yes, we have, over the course of the Meaningful Use program, seen a significant consolidation of the industry, but the vendors themselves are fatigued. And the vendors are very willing to do innovation as driven by their customers if given the chance.
Yeah, I think that is a fair point. I think it's very easy to point the finger at the big company that seems to be making all the money without necessarily wanting to look at why that ended up occurring. You know, there were clearly incentives put in place that drove us in a particular direction.
So I'm optimistic. So lest I write all these things that you might perceive as naysaying and negative, we're on a cusp of great change and opportunity. And if we just let the private sector do it, regardless of what president is elected, we're not going to discuss that. There is a possibility for a very optimistic future.
Yes, which I think, since we're getting very close to the end of our time, leads to one final question, which is, given all the public service you've done already, if given the opportunity, would you want to be the head of ONC?
So I have written about something I call a perfect storm for innovation, which is when you have government and industry and culture all aligned, you can make great change. So if I was asked to run ONC, I would have to evaluate, what is the state of culture, business, and politics? Can you make a difference? If you can make a difference, sure. If it's going to be gridlock, maybe not.
Yes, well, and thank you very much, because believe it or not, we're actually out of time already, so I'd like to thank you, Dr. Halamka, for being a great guest and for having a great conversation today.
Thanks so much.
And thank you to everyone out there for listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.